So coming to syphilis, one of the oldest infections known to mankind. So syphilis is caused by a spirochete called Treponema Pallidum, and it is not visible on light microscopy, and it cannot be cultured as well. And one has to use either dark field microscopy or serology for establishing the diagnosis. What are the stages of syphilis? Primary syphilis is going to present in the form of a painless chancre, indurated chancre at the site of contact. And secondary syphilis is going to present in the form of diffuse rash, especially in the palms and soles, and it can present with certain lesions in the buttocks, that's called condyloma lata, and it can present with hepatitis and even lymphadenopathy. Latent infection can be divided into early latent infection in the first 1 year and late latent infection after 1 year. And most of the latent infections, as far as we know, are going to be asymptomatic. And tertiary syphilis is going to present in the form of neurological involvement, cardiovascular involvement, and it can produce gummatous lesion. The classic neurological involvement is going to be the Argyll Robertson pupil and the tabes dorsalis that affects the posterior column predominantly. And cardiovascular involvement is going to be the aortic involvement, especially the aortic root involvement, resulting in aortitis and severe aortic regurgitation. So these are the various lesions that you're going to see with syphilis. So in primary syphilis, you're going to see a painless chancre, just like this. So at the site of contact. And in secondary syphilis, you're going to see maculopapular lesions and condyloma lata. This is an example of secondary syphilis. You're going to see maculopapular lesions throughout the body, especially in the palms and soles. And you're going to see condyloma lata as well. Coming to the diagnosis and treatment. So initially, you can start your testing with a non-treponemal test like rapid RPR testing, or you can do VDRL testing, that is Venereal Disease Research Laboratory testing. But RPR testing is what is preferred in practice, and it's a quantitative test, and this is kind of a screening test. For confirmation, you have to use a treponemal test only, like we have something called as fluorescent treponemal antibody ABS, or we can use TPPA as well. So you have to use treponemal test for confirmation. So neurosyphilis can be diagnosed with the help of CSF VDRL. And in the CSF, you're going to see high WBC and high protein. Both of them are non-specific for syphilis. But nevertheless, CSF VDRL is going to be the most important test in this case. And for all these infection, treatment is going to be penicillin only. For primary, secondary, and early latent infection, you're going to use benzathine penicillin G, 2.4 millinunits IM, just a single dose. And for late latent syphilis and for tertiary syphilis, you have to give benzathine penicillin at a dose of 7.2 millinunits, that is thrice the dose. And you have to give 3 doses at least. And for neurosyphilis, one has to use aqueous penicillin G at a dose of 18 to 24 millinunits per day, IV for 10 to 14 days. So that is different. Okay. So what are the alternatives to patients who are having penicillin allergy? You can use doxycycline, tetracycline, azithromycin, or even ceftriaxone. And definitely doxycycline cannot be used for pregnant individuals. In pregnant individuals, you're going to use either azithromycin or ceftriaxone. And one has to monitor the titers of these antibodies post-treatment at 6 and 12 months respectively. And the Jarisch-Exmer reaction is a febrile illness that can occur within 24 hours of treatment. And it's very common in patients with early syphilis. So in patients who are having early syphilis, you have to be wary of this Jarisch-Exmer reaction. And what's going to be the most important? Partner management. You have to treat sexual contacts within 90 days regardless of the test results. And one has to always test for HIV status as well.